The PQA Innovation Theaters are opportunities for PQA member organizations to showcase their innovations, technology services, and research in this unique forum. This is your opportunity as an audience to learn more about and ask about these innovative solutions in the marketplace. We are thrilled to launch the 2020 Innovation Theater Series with RxAnte. Sapna Patel, the Director of Clinical Services at Mosaic Pharmacy Services, is here to discuss how their comprehensive pharmacy services backed by RxAnte analytics can impact your most vulnerable Medicare populations. Sapna, please tell us more.
Good afternoon, and thank you, Jake. Today, I'll be talking about how we are taking care of medically complex and vulnerable members of health plans. Why is there a need for a comprehensive pharmacy service? At Mosaic, we serve the most complex and vulnerable members of health plans. Our process is backed by analytics from our parent company, RxAnte, to help us identify patients that are most likely going to benefit from Mosaic services. RxAnte's overall goal is to improve performances on CMS star ratings and other pharmacy measures. As seen in the graph above, there are a lot of numbers, but I want to call your attention to two of them. 36% of our members are non-adherent. These members are persistently non-adherent year after year. Furthermore, 76% of the members did receive outreach from the health plan in the prior year, but they're still non-adherent. This shows what we are doing is not enough, and there is an unmet need in which Mosaic Pharmacy is designed to fulfill. Based on our findings on the previous slide, we see an opportunity in the market exists to enroll these patients in Mosaic for medication management. There are a lot of things we can't see in the pharmacy claims or over the phone, like the SDOH factors you see here. How does Mosaic address these factors? Mosaic is a comprehensive pharmacy that brings pharmacy services directly to a patient's home. The current retail model is not built to address the whole patient and the SDOH factors that impact their medication use. Their focus is typically fragmented. With Mosaic, we partner with managed care organizations to gain a holistic view of the patient, ultimately focusing on an overall health outcomes and how we can achieve these goals with the pharmacy as the center. So what does medically complex and vulnerable look like? Risks extend beyond non-adherence and encompasses multiple SDOH factors. A comprehensive pharmacy service addresses medication-related risks and additionally manages challenges such as duplication of therapy gaps. Say, for instance, you have a diabetic patient that's not on a statin. Medication cost. Cost is a huge challenge, but Mosaic is addressing this by having access to pharmacy claims. This is allowing pharmacists to recommend medication changes, such as switching a patient from a Tier 4 medication to a Tier 1 medication. If a patient can afford their medication, they're more likely to be adherent to their medication regimen. And social determinants of health, such as poor diet, tobacco use, loneliness. Mosaic is addressing this by sending a home visit specialist directly into a patient's home. If we're in a patient's environment, it makes them actually feel more comfortable to open up and ask for help. Though with the current COVID situation, we are doing all of our visits virtually. RxAnte has identified a need for future interventions that can't be done by a phone call alone. How do we address patients that we just described or that you just saw in slide 7? This is where Mosaic comes in. Patients are identified to receive the pharmacy service offer through predetermined selected criteria, such as the number of medications they're on, or patients who are consistently non-adherent to their medication regimen. Referrals are made through physicians and health plans, and they do direct outreach to the Mosaic Contact Center. The Mosaic care model begins with enrollment. Home visit specialists will either do a virtual or an in-home visit with each member. An interview is done on their medication use. So say, for example, there was a patient that had a medication bottle in their home for a blood pressure medication that said take one tablet twice a day, but they're only taking it once a day. The home visit specialist is then prompted to ask, why are you not taking this medication as directed? Are you forgetting to take this medication twice a day? Patient may have dementia and can only remember to take their medication once a day. So in this case, the clinical pharmacist can get involved right away, figure out what medications they can recommend to switch to once a day rather than twice or 3 times a day to make it easier for them. And the other reason could be side effects. If a patient is experiencing side effects from a medication, they don't always let you know. They just stop the medication. The doctor doesn't even know that they've stopped the medication. Next step would be clinical data collection. The home visit specialist is going to collect clinical data such as blood pressure readings and blood sugar readings. And they're also going to be doing social determinant of health risks. They do this by conversation and observation when they're in a patient's home. Next step would be clinical review. A comprehensive medication review is done on each member to achieve the ideal medication regimen. Clinical pharmacist is going to take a look at all the medications the patient is currently using in order to identify potential ADRs, ineffective drug therapy, incorrect dosing, missing medication, or even drug interactions. Through pharmacy claims, the pharmacist can determine if a patient is being adherent to these medications. Adherence issues are mostly related to cost and side effects. Having access to pharmacy claims, the pharmacist can also easily make formulary changes to a more cost-effective medication. This is done by sending clinical recommendations to the doctors. A complete list of medication is sent with these clinical recommendations. Once those doctor has responded to those recommendations, changes are made, and then we will go on to the next step of dispensing and delivery. Medications are synced to fill once a month in adherence packaging. Now, adherence packaging is good for 2 reasons. The first reason is it helps the patient stay organized. And the second reason is if a patient has a caregiver in the home, caregivers are not allowed to dispense. So if a caregiver opens the vial, and takes the pill out of the vial and hands it to a patient, that's considered dispensing. With the adherence packaging, they can just rip the package open, pour it into the patient's hand. They're not touching the pill, so it's not considered dispensing. Next step would be ongoing monitoring. Each patient gets a 10-day outreach call every month before their next box goes out. We do this for several reasons. The first reason is because we want to make sure everything that's going out in that box is correct. Say the patient had a doctor's visit a week ago and a medication was discontinued. We don't get discontinued orders. So we wouldn't know if that medication was discontinued unless we ask the patient or if the patient gives us a call. And sometimes the doctor puts the patient on a new medication that needs to be started right away. So they call it into their local pharmacy. We want to make sure we transfer that prescription over so we have the medication when we fill that next box. The other reason is we also want to make sure we send any of their bulk items, meaning items that are not pill form. We want to be able to sell their inhalers, eye drops, insulin. We want to send everything in that box. I want to share a challenging case study that I did recently on a patient that was on 47 medications, both prescription and over-the-counter. Background on this patient, she's a 59-year-old disabled female with an extensive past medical history. She's currently on 47 medications, both with over 20 drug allergies, and she had 6 different doctors. Her drug therapy problems included multiple duplications of therapy. She was on 2 PPIs. She was on 2 antihistamines, 2 sleep aids. She was also on 2 overactive bladder medications, and she had 3 vitamin B supplements. Adverse drug reactions caused this patient to have hallucinations and severe constipation, and drug-drug interactions caused her to have rapid heartbeat. So if you take a look at that picture on the right, this is what the home visit specialist walked into. These medications were all laid out on her table, on her kitchen table, and if you take a closer look, towards the back, there are 3 Ziploc bags that are also filled with medication. Interventions made here, recommendations were made to deprescribe 20% of her medications. A bone density test is being scheduled Patient was on 2 PPIs, and she's been on them for over 2 years, so she does need some additional monitoring. Patient has been started on the Mosaic synchronization program, and she was also educated on monitoring healthy diet and adherence. Outcomes in this case, the patient is now on 37 medications, and the pharmacist is working with the provider to de-prescribe additional medication. Cost savings to the patient in copays was $62, and cost savings to the health plan was about $1,200. If you take a look at the picture on the right, this is the after picture. Those 2 boxes that are in blue are the Mosaic medication boxes that have our prescription medications in it. And the bags right in front are the takeaway bags that Mosaic provides. These bags are provided to the patient so they can put any expired medication or any medication they're no longer taking in. They can seal those bags up and mail them out. We don't want any expired medications or any medications they're no longer taking in the patient's home. Now she still does have 1 Ziploc bag of over-the-counter medications. In this case, the patient is actually getting her over-the-counter medications through a state plan for free. So the patient follow-up in this case, she's doing very well. She's not having hallucinations anymore. And she's very thankful for Mosaic getting involved. In this case, the patient was not even aware of all the duplication of therapy she was on. All she knew was that she's on way too many medications. The combination of a home visit, access to pharmacy claims, and clinical pharmacist interventions is what ultimately helped us to provide a level of service that offered enhanced safety, cost savings, and simplicity for this member. And this is what makes Mosaic unique. So think back on a couple of slides ago where I showed you the kind of problems that we're finding in members' homes. Most of our members have an average of 12 medications, upwards of 30, but our patient had 47, and an average of 3 prescribers, upwards of 11. This is what drives the problem shown here. 62% of missing important medication, 54% taking unnecessary medications, and about 25% of the members were experiencing all of the above problems. So why is there a need for a comprehensive pharmacy service? The predominant intervention tactics are not always enough. Mosaic's idea of sending a home visit specialist into a patient's home has helped address the SDOH-related factors of non-adherence in the medically complex and vulnerable patients. How is Mosaic making a difference? Mosaic is providing these long-term care services in a patient's home by incorporating a pharmacist from the beginning into the continuum of care. By doing this, we're helping the patient and the health plan achieve regimen simplicity, consistency, safety, and cost effectiveness. This concludes my presentation. What questions do you have?
Sapna, thank you so much for this presentation and sharing some of the great work that you're doing at Mosaic Pharmacy. So we've had a couple questions come in through our Q&A, and so I'd like to start with where are you currently providing services? So where is Mosaic Pharmacy and what are they doing?
Yes, thank you, Jake. Currently, we're providing services to our health plan clients in New York, Florida, Georgia. We're in Maryland, Tennessee, and Pennsylvania. We are licensed in 12 states and plan to be licensed in all 50.
That's really exciting. Do you know when, you didn't mention Alabama, and as I said, that's where I am. So do you know when you're going to get available to Alabama? Like, what's the game plan? Like, are you going to get all 50 states by the end of the year? Is that like a 5-year goal?
Definitely not by the end of the year. We're definitely less than 5 years is what we're hoping. Alabama, it all depends on what health plan we're working with and what states they'd like us to start in.
Perfect. Makes a lot of sense. So then how are you handling the current coronavirus pandemic? How has that impacted some of the work that you do?
So we're currently conducting all of our member onboarding processes via phone. So this includes the medication use interview that we talked about and also the clinical data collection. We're also introducing telehealth, televideo, so we can consult with patients onboarding, and also a pharmacist can also do telehealth with the patient. Our partnership with the Medicare Advantage plans provide us with members' historical pharmacy data. So this is great because when a home visit specialist begins their process with the patient on the phone, they can take a look at these historical pharmacy claims data to see if a patient is being adherent to their medication. This also helps dictate questions that they have when they're talking to the patient. Currently in the pharmacy, we are taking all the necessary precautions by using PPE, and we're also limiting the number of personnel we're allowing in the pharmacy. We are only allowing critical pharmacy personnel. Everybody else is working from home.
Perfect. Thank you so much for helping us understand some of your work in that area. So another kind of thematic area that has come up with some of the questions that are coming in really goes back to this idea of the expansion and getting patients on board. And so you talk about partnership with payers, and that's how you're kind of expanding services. So is there a way for a patient to just like walk up to the pharmacy, or is this really focused on kind of partnering with that payer and connecting through that channel?
Currently, we do not have walk-in patients. All of our patients are referred to us directly through health plans. The health plans do have a predetermined criteria that they're following on who they want to recommend to Mosaic Pharmacy. Of course, the most vulnerable patients are being recommended to us. We've seen patients anywhere from 10 medications, 47 is the most I've seen so far, but recently we've also seen patients coming in with 35 to 40 medications. And it's very challenging for them. They're seniors, and it's really hard for them to manage this on their own. A lot of times there's a formulary change on a medication. When they go to a retail pharmacy, they're told the prescription's not covered, so they just don't get it filled. So we want to be able to intervene right there when we're in that patient's home, so we make sure they're on the correct medication as soon as possible so they don't end up in the hospital.
Perfect. Thank you so much. And so we only have a little bit of time left. So this last question really thinks about recognizing things or aspects of our healthcare kind of vary by condition. So is there evidence on the maximum total number of medications a patient can effectively manage in both terms of adherence and their outcomes? Like, is there kind of that threshold that you're looking at saying like, they're on 40 meds, I got to get them down to 10, or is that just too much of a cut for a patient?
It depends on the patient. On most patient, it is too much of a cut because we have to also be mindful and realize that we're coming in new. We're learning about this patient. This patient has had multiple providers for multiple years. So we have to make sure whatever recommendations we're making, we realize that we need to speak to the providers first. Some of these patients are self-medicating with over-the-counter medications. That's where we're trying to make a difference. They don't need to be on 20 different over-the-counter medications. A lot of times they say, well, I've read this medication is good for this, and it's not a prescription item. So that's where we do try to talk to them and say, hey, you don't really need to be on all of these over-the-counter medications. When it comes to the prescription items, we do want to make sure that we talk to their providers and get a full view of what is going on before we make any kind of recommendation.
Perfect. It sounds like you're a very needed support and member of that healthcare team to our patients, both and with emphasis on those in the geriatric setting or those that are geriatric, because that's a definitely needed area to help support and care for our patients. So Sapna, thank you so much for this presentation and sharing everything that you do with your pharmacy.